Tonight, we embark on a journey that's deeply personal to me and potentially life-saving for many of you watching. In recognition of Colon Cancer Awareness Month, we're taking an unprecedented step to confront one of the most common yet preventable forms of cancer in the Western world. For too many of us, colon cancer remains shrouded in fear and misunderstanding. It's a disease that has touched my life personally, taking my father last year. His loss was not only a heartbreak for my family, but a wake-up call about the realities of this disease and the importance of early detection. In a bid to break down barriers and demystify the process, I will be undergoing a live colonoscopy. It's a decision that comes with its vulnerabilities, but one I make openly to show that if I can do it, so can you. This procedure is a critical step in early detection and prevention, and I hope that by sharing this experience, we can quell any fears or stigmas associated with getting checked. This is more than just a television episode, it's a mission to save lives, a tribute to those we've lost, and a call to action for everyone. Stay with us, our journey begins on the other side of this break. Like all surgeries, we began our journey with the consultation. We walked into the office of gastroenterologist Dr. Jamarol, who welcomed this idea after checking in with her helpful staff and filling out all of the necessary forms. I was escorted to an examination room filled with charts and pamphlets to have my vitals taken. Research has shown that while there are numerous factors affecting colon health, like diet and lifestyle, what was surprising to learn is that those of us of African descent are at a higher risk for colon cancer. Once my vitals were complete, I was greeted by the good doctor to begin our consultation.
Jerome, glad you can make it here today.
So I'm, I guess, excited, nervous, curious. This isn't my first colonoscopy, but it's been a while since I've had one, and obviously there are going to be some things that are of importance that I do want to talk about. So I'll let you do your job, quizzing me, and then we'll see what we come up with.
So this year made you how old, Jerome?
52.
So you're 52 years old. Congratulations. This is not your first time having a screening colonoscopy. You've had one in the past, I believe you had said about 5 years ago. Which at the time you had your indications for that, but I do understand that your father had his history of colon cancer
And
prostate cancer.
Yes.
So just by family history alone, you are at an increased risk of your own malignancy, okay, colon cancer. So unfortunately, you're not one of them that can do a normal colonoscopy every 10 years. You perhaps have to check more often. And 5 years is a good enough time to repeat that, right? Have you ever been diagnosed with a polyp?
Yes, actually, during my very first colonoscopy, I was informed afterwards by the doctor that they had removed some small polyps at the time. But that was, I think, probably about 10 years ago now. So yeah, I think the risk factor is there for me.
Yes,
It's something
definitely.
I always think about. Because as you mentioned, my dad um, had both colon and prostate cancer, but his first bout was with colon cancer.
Yes.
Yeah.
So for you personally, a history of having polyps, you should have colonoscopy more regularly. Persons with a family history, a first degree relative at that, of colon cancer, you should have a surveillance colonoscopy. Any issues with your bowels at this time?
So, I'm very regular. I say that to my doctor all the time. I have no issues. Now, I do make jokes about it, but I do frequent the bathroom quite a bit. I have a very active bowel. I pee a lot.
Okay.
There are some medications that I've been put on to try and deal with that, but that concerns me, and I always wonder whether that's connected to any health issues. And I literally always say I have a 52-year-old man problem. I like to pee. I always gotta pee. But I'm always curious, is there any relation between the two?
Well, having bladder issues or frequent urination, you would think that there's some link to prostate health, prostate cancer. There are other reasons for a man to, or anyone to have frequent urination, something called an overactive bladder, which has nothing really to do with the prostate. But the medication that you're on or had been recommended is to decrease that overactivity of the bladder, okay? And it's not a precursor to cancer. It wouldn't be something that you should be concerned about with prostate cancer, and certainly not colon cancer, okay? The two aren't really connected with that. But at the same time, there are some symptoms, urinary symptoms, that a man may want to be concerned about related to the prostate. That would be urinary hesitancy, or not having a good stream of flow of urine. And then when there is prostate enlargement, you may have frequent urination, mostly at night. Men would complain. But again, it may not have to be prostate cancer. Just an enlarged prostate itself can cause those other lower urinary tract symptoms.
So for me, once you hit the 40 threshold, life changes, and you notice the changes in your body. By the time you get to be 50, those changes are more pronounced, and you start to think about what types of things do I need to be looking out for, particularly when you have that family history. So for me, I'm always looking or asking myself, how do you feel? Is this something you need to check? So I guess my question is, what are the symptoms, or are there symptoms that you may be having some issues with your colon?
Well, when we think of colon cancer itself, let's remember that one of the most common symptoms is to have none at all. You don't have to have any symptoms or signs of colon cancer, and you may be victim of colon cancer, okay? One of the things that I would encourage everyone at a certain age, definitely 45, you start having your screening for colon cancer. You go and look, even if there are no symptoms, because you have reached that milestone of 45, and this is the age that we start screening in the average risk population. Now, when I say average risk, I mean that you have no family history and you don't have a personal history of having a GI issue. You've reached 45, time to have a colonoscopy.
That's if you don't fall in that category of a family history. But let's say you do.
Okay, so let's say you have a first degree relative or two second degree relatives.
So like mom, dad.
Right, or a sibling.
Okay.
Right? You would, 10 years prior to that family member's diagnosis, you start your screening. So if your father had colon cancer at 45, you would start your screening at 35.
Wow.
Okay? or that's colon cancer, or what we call an advanced polyp. Now, some patients don't really know the degree or the severity of the polyp that they may find. It may not be cancer itself, but it's a minute away from becoming cancer. So, you're in the same category there. Now, rather than wait for some symptom, because there are symptoms of having colon cancer, I would encourage everyone to see their doctor regularly, an annual visit. With an annual visit, a patient should have their blood work done, where we're checking the basic things. We're checking your liver function, your kidney function, your how much blood you have circulating, whether or not you're anemic. These are your protein levels. So these are things that a physician may be clued in to say there may be something going on unbeknownst to you, right? And then it would prompt further investigation.
So when I think annual physical, I know better, but when most people think annual physical, as a kid, they tap your knee, listen to your heart, those kinds of things. But as the patient, what should you go in looking for your physical? Because an annual physical to you may be one thing, but to others they're just not sure. I'm just going in to do my physical. So once you hit that, whether you're 10 years from where your parent had, or whether you're in the no risk zone at this point, when you're going for that physical, what kinds of things should you be asking the doctor to do?
So a general examination, a general physical examination, the doctor may look into your eyes, they may look into your mouth, they may feel your neck, listen to your neck, listen to your heart, listen to your lungs, do an abdominal examination, feel for any abnormalities there, any tenderness, any growths. They'll look for any swelling in the legs. When we think about things like more focused exams, like your nervous system reflexes, like hit the knees and stuff like that, you don't really see that on an annual exam unless a patient may complain of something, or look at the range of motion of their limbs. You may say, "Doc, I have some pain in the shoulder." They may do a focused exam on that, based on your symptoms. But just in general, we're looking for clues that something may be happening internally. And then, of course, we're checking your blood pressure. Is your blood pressure okay? Because that's not something that you would have any symptoms of unless it's, really elevated. So check your blood pressure, your heart rate, just looking at you, if you're not breathing heavily or having any signs of something happening. Look at the skin, any rashes, easy bruising, things like that. Just general exam. And if I can answer a question about what symptoms you may have that may suggest colon cancer, there could be abdominal pain, unexplained, right? There could be a change in your bowel habits where previously you had a bowel movement every day and now you have to struggle to have a pass every 2 days, or there's a change in the caliber of your stools. Your stools are now pencil thin, perhaps, or even being more bulky. You may see blood in the stool. You may see blood when you wipe. You may see blood on the actual stool or drip into the bowl. In a person that hasn't been screened for colon cancer, rectal bleeding is always abnormal, or I should say not a normal thing. It's not something that you should expect.
Now, a lot of men will say, listen, I am fine, I feel fine, I'm generally healthy, I'm moving, I may or may not go to the gym, I may or may not exercise, I eat kind of okay, I feel fine. Mm-hmm. Like there's no indication. But I know from experience, seeing, and hearing the stories of those men who check, and at that point they're at stage 3 or stage 4, why is it still important for you to get those annual checks?
Okay.
Even though you feel
fine. So Great. Now, in a man's annual exam, you have what we call a PSA, which is a prostate-specific antigen. It's a simple, inexpensive blood test that will tell you about a possible prostate cancer, right? A prostate malignancy. You're getting your PSA every year. Every year the doctor says it's normal. Great, because you don't have any symptoms or signs of having a prostate issue, no one in your family with prostate cancer. You're getting your PSA every year. And every year it's normal, less than 4. And then suddenly, this year, it's doubled. The velocity, the rate of increase, it doubled from one year to the next. Unbeknownst to you, you have no symptoms. This would prompt further investigation. This may allow your physician to refer to a specialist on the prostate and let them say, hey, you increased from one year to the next because maybe something else was going on and you're in the clear. But you would not know that, a lot of men die for other causes, with prostate cancer there, just undiagnosed. But, that speaks to prostate cancer being something that can be very asymptomatic until you have symptoms. And catching it at a time when we know our PSA rose, doubled from one year to the next, right? Could save a life.
A lot of men out there who say, I don't want to know. They are literally afraid. How do you convince those men? What do you say to them? Say, listen, I don't want to know. I'm scared. I'm or they'll put out that facade, man. Listen, it is what it is.
It is good, yeah.
How do you deal with that? And I'm asking that for wives and children who may be watching, and dad hasn't been to the doctor in 15 years, in 10 years, and you can't get him to go. How do you begin to have that conversation?
It is a challenge. It is a challenge, especially in our culture. We got machismo men. We got, we are men. It is a challenge. I think that I would win the Nobel Prize, for the answer for that. But what I do try to make a patient as comfortable as possible. You're not my first patient with this challenge, and you won't be my last. Sometimes I tell stories of patients that I've had bets with people that, everything will be fine. I won't find anything. And the last one that happened to, maybe he's watching, but the last one that happened to ended up having stage 4 colon cancer with absolutely nothing, no symptoms whatsoever. Okay? Big mass in the colon, couple spots on the liver. I would never know. And just came on a hunch to prove that he's okay.
He was okay.
Right? So sometimes that helps.
At what point, at what stage, if you've got to catch it, should you really, at what stage should you try and catch it? And that's almost a silly question if I can say that. But what's the best stage to really catch it where you can help that patient?
So, a couple ways I can answer that question. So the beautiful thing about doing a colonoscopy for colon cancer screening is that it's preventative. In fact, of all the cancers, it's pretty much the only screening tool that we can actually prevent colon cancer from happening by having a colonoscopy, right? Because during the colonoscopy, through the scope, through that tube that goes into the rectum, we can remove polyps. Polyps are growths in the colon that, if they stay inside, can grow into a cancer. All cancers start from a polyp. So during the colonoscopy, we remove them. The colon is a hollow tube. So if something is growing into this tube, there's no nerves inside that will say, okay, this polyp is causing pain. You can still form stool that can pass a small polyp. So you would have no idea that you have these polyps growing. So you do a colonoscopy and you remove them. That eliminates the risk of colon cancer from those polyps, okay? So that's pretty much where you want to stop it from happening. Now, we can speak about cure of colon cancer if you have a lesion that's limited only to the colon. It hasn't spread to a nearby organ or hasn't spread to nearby lymph nodes. But even still, during your surgery, to remove a colon cancer, the surgeon would take all the lymph nodes nearby, get them tested, and see what your stage is, and technically you're cured. Now, your surveillance afterwards for the next 10 years or so may be a bit more frequent, but we speak of cure in patients with stage 2, depending on, the depth of the lesion. Even with some nodes there, we can still speak of cure. So I would say you want to catch colon cancer before it forms. And if you do, you can have a stage 1 cancer where it's only in the colon, remove it. You can speak of cure. And even at more advanced stages, removing all disease that's there, you can still consider curative.
What is the expectation for me over the next few hours?
Well, Jerome, I'm so happy that you would have at least had this experience before, right? So you would be what we call a veteran of colonoscopy, right? At least having it at least once. You're a colonoscopy vet, but the hardest part about colonoscopy really for patients in terms of the action that they have to do is the bowel prep, okay? The bowel prep. So you've been on clear liquids, for the whole day, the day before the procedure, okay? And those liquids are important to start that cleaning out process. You wouldn't be expected to start having bowel movements until you start drinking this large volume laxative, and I have, we have it here for you. So a lovely gift that we have. This is your bowel prep, where there's a little powder on the bottom here, and you're gonna fill it with water to the fill line. This is what I would want you to drink, 1/2 this evening and the other half in the morning, because we're gonna do your procedure in the afternoon. So you would drink 1/2 this evening, the other half in the morning.
Okay.
And then we have
about what time this evening?
So you can start between 6 and 8 p.m.
Okay.
Right? Start drinking, and you would drink half of it. And then first thing in the morning, I would say you should get up around 4 a.m. and drink the second half.
Set my clock.
Now, each half you should drink over 2 hours. The faster you drink it, the better, right? But drinking it within a 2-hour span, okay? And then you'll take these little pills just as a stimulant laxative to help to kickstart the bowel and get things moving. Yeah, there's 4 in there, 2 tonight and 2 in the morning. Okay. You wouldn't be able to drink anything within 4 hours of the procedure start time. And that's pretty much because during the procedure, you'll be sedated. And when you're sedated, we just want to make sure that your stomach isn't full of liquid and you just aspirate, because, some comes up into your mouth, and because, you're asleep, you don't breathe it in. Okay? So the action won't be until you've consumed a good majority of this laxative.
Stay with us. When we come back, it's Operation Day. You're watching On the Record. Just as the doctor ordered, I drank the bowel prep at the appropriate hours and slept a few hours more, then headed to where the procedure would take place. Nurse Bodie checked me in and proceeded to walk me through what would be happening today.
What's your name?
Jerome Sawyer,
And what procedure are you having today?
colonoscopy.
Great. So, when was the last time you eat?
So, It was early yesterday, not yesterday morning, but around noon yesterday. But it should have been earlier, I know. But I was hungry. I hadn't eaten all day, so yeah.
What did you eat?
Oh Jesus! I ate a burger.
All right. So what time you start the prep?
About a little after 8 last night. That's the time that Dr. Rowe told me. So about 8 o'clock last night. Yeah.
And what time did you finish it?
So I set my alarm for 4 a.m. and I did the other half at 4 a.m. this morning. Yeah.
And you drank all of it?
Yes. Yeah.
Okay. And then you go to the bathroom.
Okay, so it was like a rainbow. No, it was different colors. So I kept checking.
From darker to lighter.
The darker to lighter, yes. And then at one point it was just, it looked like just all clear. Yeah.
Beautiful.
Mhm.
Okay. So, any cough or cold recently?
No,
And how tall are you?
6 feet,
And your last weight?
about 225, somewhere around there. Yeah.
No allergies to food or anything.
No.
Past surgeries before?
I had an appendectomy about 1995. I think that's when that was done. Yeah.
And you didn't take any medication this morning?
No, nothing.
Any problems chewing or swallowing?
No.
Any acid reflux or indigestion?
No.
And no post.
Nope. All mine.
So, we're going to sign some paperwork.
Mm-hmm.
I have insurance paper here, consent form, and discharge instructions.
Okay.
We're going to sign here.
Mm-hmm.
There for me. This is your discharge instruction, sign right there. And the consent form, this gives us permission to do the procedure. Print your name, address, and signature right there. Beautiful. All right. So is this the first time having this procedure done?
No, I've had it done before.
Beautiful. So you're more familiar with what we're going to do.
I know sort of what to expect.
All right, so you know we're going to take off all the gloves.
Mm-hmm.
Yes. We're going to establish an IV on you. That's to give you some medication and let you fall asleep and replace the fluids that you lost last night.
Yeah, I'm very hungry and very thirsty. I just want to put that out there.
When the procedure is done, trust me, you'll be happy to say,
Yes.
I can eat and I
So,
can drink.
first question, what can I eat?
You can start with a light diet.
Light?
Light,
Jesus.
soup, a salad.
Okay, just something to get
Yeah.
the food in my system.
We're
And
gonna
then,
give you some tea or coffee before you leave
okay, all right.
to help with any gassy feeling you're having.
Okay,
And
all
then you
right.
start with something soft, and then later on today,
Mash time.
mash it up.
All right.
Alright.
All right.
So now you know this is a medical facility. We're
Yes.
doing a procedure on you. So there's always a possibility of risk of infection. So we're looking for fever, chills, loss of appetite, anything like that happen within the next 5-7 days or so, contact our office. Okay?
Mm-hmm.
All right.
Okay.
So we're going to get you changed and ready to go.
All right.
All right.
Adorned in the fashionable garb, I was given my IV, and the next person I saw was anesthesiologist Dr. Cy Pierre, who took me through the process.
Mr. Sawyer.
No, let me shake with that on.
Yeah, it'll make a difference. Again, I'm Dr. Pierre. I'm the one who's going to be conducting the anesthesia. You're not going to have a general anesthetic. You'll be awake, not awake, you'll be breathing on your own with little supplemental oxygen.
Okay.
With regards to risks, very few risks involved, but if you want to get an idea, you probably have about 1,000 times more likely chance of getting in a car accident than something going wrong in here.
Gotcha.
Okay? What's going to happen is after we finish speaking with one another, I'm going to put some sedation through this IV. And Ms. Roller so nicely started for me.
Uh-huh.
After that, about 2 minutes later, you won't remember a thing. All you'll know is you went to sleep, and when you wake up, you'll be back here.
Okay.
Now, after I take you to the operating theater, we'll put all the monitors on to keep you safe. Watch your heart, blood pressure, kidneys, oxygen in your blood, everything. This procedure is not normally painful, but I'm going to give you medicine to prevent nausea, vomiting, cramping, and pain.
Okay.
Once that's in, I'll start the heavy sedation. Once
Okay.
you're safe and asleep, Dr. Rule will get started. Once she's done, I will shut the anesthetic off, sedation, and bring you here to complete your recovery.
Okay.
When you wake up, if you have any pain, cramping, nausea, anything like that, makes you uncomfortable, let us know early, and we'll give you something for it, okay?
Okay.
Do not resume your normal activities for the next 24 hours.
Okay.
Because you're going to feel fine, but you're technically not capable of making decisions.
Gotcha.
All right?
All right.
Anything? Questions, concerns?
No. Like, do you? Will I be awake partially or not at all? Or?
Not at all.
Right.
Completely asleep.
So, you know, I have national secrets. I just want to make sure.
No. No, you're going to be totally asleep. You'll be breathing on your own. You won't be on a ventilator, but you will be
Gotcha.
unconscious.
All right.
All right?
That's it. All right. Good to go.
I think they could. I don't know. You might. This is the time I usually ask you if you drink alcohol at all.
Skip that.
I should say excessively.
Yeah.
All right. I don't know how long they want to record you because you're going to start getting kind of sleepy in a minute.
I'm gonna get sleepy in a minute.
He's going to start getting very sleepy. All right. I need you. I'll turn you in. That's it.
Okay.
You breathing okay?
Mm-hmm. Good. Feel fine. See you also. Right? Oh yeah, that was good.
Bring this hand in for me.
I did it.
Yeah, you're drifting.
Yeah,
he's drifting.
Yeah.
Come here, Bill. Sorry, boss.
No, you're good, man.
All right.
It's like I'm floating.
You getting loopy?
Yeah.
All right.
Very relaxed.
Huh?
Very relaxed.
His tongue is
Lady. Hi, ladies. You're gonna look at me another way now, right?
This is fun. I know it ain't good, you know. All right.
That's a fancy room.
This is the operating theater. This is where all the action is.
As I drifted away, it was time for the good doctor to take over and walk us through exactly what was happening.
So basically, TC, what we have here is this is where the magic happens. This is the tool that we use for colonoscopy. It's a colon scope. This is the actual scope that's going to go into the patient. This is our equipment that transmits whatever images we have to the screen. I'll be watching. We're now into the patient's rectum. I'm using some air to open things up so that I can visualize the entire colon. The large intestine is in a straight tube, so there's going to be twists and turns. And as I pass the scope through, I'm gently insufflating air. I think I need a little flush. So my assistant is just passing some water through. It helps with the passage of the scope. So here we have the beginning of his colon. I know that I'm here because to the left of the screen is the part of the anatomy that shows me the small intestine entering into the large intestine. And this here is what we call the orifice of the appendix that tells me I'm at the beginning of his colon. during the procedure, I can take pictures for documenting the landmarks as well as documenting any abnormalities. So now that I'm at the beginning of his colon, this is where the examination starts. And as I start to withdraw the scope, I look behind every fold, looking for anything abnormal. So we have bubbles here. What my assistant is doing, she's flushing it with water that's treated with Infocol, because sometimes bubbles can obscure the view. So balancing out the right amount of air to keep the lumen open, and bearing in mind that the colon is constantly involuntarily moving, trying to pass that air out and just move. You move the scope based on how you see the bowel moving, and you want to just keep that balance of the right amount of air to open up so that I can see all the walls. You know, after doing this for so many years, it's almost like trying to explain to someone how to ride a bike. You know, it's, you just feel the movements and anticipate the turns that you have to make. With my left hand, I'm adjusting the dials, left, right, up, down. With the right hand, I'm using torque and pressure to push in and out. So the combination of both hands is what gives me my views. So we're almost finished with the colonoscopy. We're approaching the rectum, and there's certain, again, like I knew, hold on, I found one. Like we were at the beginning of the colon, there was a landmark, an identifier to show that we were at the beginning. There's certain landmarks that tell me where I am in the colon based on how much scope I have left. But here, in one portion of his colon, we see what looks to be a small polyp. It looks very benign. This is about 3 millimeters in size. You can see that the appearance of the mucosa or the lining has changed. We can see a circular, circumscribed area. Yep, this is what a polyp could look like. It's rather benign looking.
Was it 12 o'clock? Well,
Right smack dab in the middle of the screen. Yep. So, my trusted assistant, Mrs. Pratt, just handed me a biopsy forceps that I'm going to pass through the channel.
did you go on the channel?
And I just removed it. So you can see the minimal bleeding, sigmoid polyp. The minimal bleeding that occurs, I watch it for a second. And then I continue the procedure. So one small, tiny, benign appearing polyp in an area called the sigmoid was removed. Now, don't forget, this is the reason we're doing this. We're not only looking for colon cancer, we're looking for these little things that if they stay inside, have the potential to grow into a cancer. want to grab them up before they have the chance to grow. Am I concerned about this polyp? Not really. And here goes another one. So we start screening for colon cancer at the age of 45 in average risk individuals, persons who may not have a family history. I can start with this. May not have a family history or have any personal GI issues. We just started because they've reached that 45-year milestone in their life. Start at 45 to screen. Now, people with a family history may want to start earlier. We have guidelines for that as well. So just found another little polyp. We see that pale circular spot open. This is sigmoid 2. So we just took that. Again, minimal bleeding. He doesn't feel it. So that's in an area called the sigmoid. And so what Mrs. Pratt has done, if you could just show that, she took the specimen off of the biopsy forceps and put it into a little container. And from there, we will send that pathology to a lab. They'll look at the specimen under a microscope and tell us exactly why that polyp formed or what that polyp is. So I have another one.
Another polyp?
Yep. Rectum.
This is rectal, not sigmoid.
Rectal polyp, yeah. So now here we have just a slightly larger polyp. This still looks benign appearing. This is this pale circular growth. We're in his rectum at this point.
Terrible.
Going to use the same biopsy forceps. By the way, everything is somewhat sterile. We use brand new biopsy forceps on each patient. This minimizes the risk of infection. So we throw these forceps away. Now, before I remove the scope completely, what I'm going to do is I'm going to turn the scope back on itself, the rectum. And here we have just inside, it looks a little reddish. The rectum is a very vascular part of the colon. He has some hemorrhoids here, these little bulges, purplish swellings. These are hemorrhoids. This is what hemorrhoids would look like. Hemorrhoids may form if there's a lot of straining to have bowel movements, sitting on the toilet bowl for a long period of time. Persons may develop hemorrhoids with weight gain, pregnancy. You would treat with a high fiber diet, taking fiber supplements, perhaps stool softener. So overall healthy colon here. And we're complete.
Right.
And so what Mrs. Pratt will do is after each procedure, we sterilize the equipment, right? So what'll happen is during the procedure, we took pictures of his colon, documenting the little polyps, the hemorrhoids, the small bowel, the beginning of the colon, and my assistant, she has transcribed the report for me, print that out, and patient leaves with his pictures, an actual report, so that after he's at home and in his comfort, he can read up on everything that was done today. So Mr. Sawyer will know right away what his findings are. And based on what we found, he will likely require a repeat of his colonoscopy in about 5 years because of his increased risk of colon cancer from his family history and the fact that he's had polyps.
And just like that, in under 30 minutes, I didn't feel or know a thing that had happened. All that was left to do was for me to wake up. When we return, Dr. Roll takes us through what she found. Stay with us. You're watching On the Record. Though delirious, I return to the land of the conscious. I'm greeted with a lovely bedside manner and ecstatic about my first meal post-op, tea and cookies.
Right. So Dr. Rowe will come and speak to you shortly, so you'll know exactly what she saw, what she did to you, okay?
All right, Jerome, you did a great job.
You do?
Yes, you did. You were nice and clean, didn't have to do too much washing. Was almost able to tell you this was a completely normal colonoscopy until I found just a few little small polyps. They do appear quite benign. And of course, as I had told you, anything abnormal we're going to biopsy or completely remove, and that's what we did. Okay? So you'll see here on your pictures, you see this little circle here, this little spot. Just snip that away. That's a polyp.
You want to see these?
We got that.
Oh, you want to see that?
Yeah. Mm-hmm. And then just a little tiny little polyp right there. Snip that away. This is the rectum, some small hemorrhoids here. These little reddish, sometimes they're purplish bulges here. These are internal hemorrhoids. So during the procedure, at the end of the procedure, pretty much we take the scope and we look back at the rectum just to find any abnormalities there. So otherwise, healthy colon. Okay? So the recommendation for you would be to repeat your colonoscopy in 5 years, right? So people who have these little small polyps that show up, we kind of don't want you to go for 10 years as if it were completely normal.
So they can eventually lead to...
Right, so that's the concern with polyps, that these little things, if they stay inside and grow, this is the precursor to cancer. So we remove them during the procedure. And so what you get to take with you is your full report. It describes everything that we did during the procedure, what the findings are, and also your recommendations. So that just in case you don't remember this conversation, you can always go back and take a look.
So
Okay?
for the benefit of the audience, what are the recommendations?
So the recommendations is, first of all, you start colon cancer screening at the age of 45. If you have a family history, depending on the age of that family member who's had colon cancer, you may want to start a little earlier. You want to screen for colon cancer with or without any symptoms, just 45 years old. A parent or a sibling had colon cancer at 50, you want to start your screening at 40, right? If you have any polyps, you don't want to wait for 10 years as you would with a normal colonoscopy. You would get it done in 10 years. You want to come a little earlier, 5 years maybe, sometimes even sooner. but certainly start at 45 and keep on going from there.
And the removal of the polyps is really the preventative.
Correct. So removing those polyps prevents the colon cancer. And you'll see when you look back at your procedure, the minimal bleeding that resulted. And you know, you're sitting now, do you have any pain or discomfort?
Yes.
Yeah, so during the procedure, you'll see I had to put air in there just to open things up. It's an empty lumen. Put some air in there to open it up. And so that gas is what we would encourage you to just keep passing as you go along your way.
Colon cancer, unique among its peers, holds the dubious distinction of being preventable through regular screenings and checks. This message is the cornerstone of our discussion today and cannot be overstated. The power to prevent lies within our grasp and is a testament to the advances in medical science and the importance of proactive health care. Our heartfelt thanks extended to Dr. Gemma Roll, whose wisdom and unwavering dedication have not only shed light on the path to prevention, but have also served to demystify the process and humanize the experience. To the entire gastroenterological and internal medicine team, whose behind-the-scenes efforts make the health journey possible, your commitment and care do not go unnoticed. To you, our audience, thank you for joining us on this journey of awareness and action. Till we meet again, take care of yourselves and each other. And remember, the power of prevention is in your hands. Good night. We'll see you next time.